Doctor, we are live now.
Thank you. Tamil Nadu Ophthalmic Association proudly presents Meet the Legend, a special webinar honoring pioneers who transformed eye care through passion and purpose. Discover their journey, insights, and legacy. On this first edition of Meet the Legend, we are privileged to feature Dr. G. Nachyar Ma'am, Director Emeritus, Aravind Eye Care System, a beacon of compassion, vision, and service in eye care. Join us as we celebrate her inspiring journey that continues to touch countless lives. At the outset, I'd like to welcome Dr. Shalini, Dr. Shanti Selvam, Dr. Ravi Shankar, and Dr. VRB Sir, along with Dr. DC, and all the other members who have joined, all the faculty who have joined. So before we start, I would like to make a formal introduction about ma'am. And this first slide says Dr. G. Nachyar, Mission Beyond Vision, a journey of compassion, leadership, and social impact. Born in Tamil Nadu, India, she was one of the first female ophthalmologists of her time. She completed medical education and specialization in ophthalmology in 1969, specialized in ocular pathology at University of Illinois, non-clinical fellowship at Harvard. She was deeply influenced by her brother, Dr. G. Venkataswamy, fondly called as Dr. V. She was a co-founder of Aravind Eye Care System along with Dr. V and Dr. Nam. She shared the founding dream to eliminate needless blindness. She helped shape Aravind into a global model of sustainable eye care. Quote, "We wanted to serve not just to treat eyes, but to open minds," unquote, Dr. Nachyar. She served as a head of clinical services and later director of human resources. She played a key role in training more than 2,000 ophthalmologists in microsurgical techniques from India and abroad. She pioneered quality assurance and ethical patient care systems. She developed training programs for mid-level ophthalmic personnel, and she was a strong advocate for women in medicine and leadership. She was also instrumental in recruiting and mentoring women from rural backgrounds. She empowered them to become skilled eye care professionals. Dr. Nachyar also headed the neuro-ophthalmology and cataract departments. She coordinated community outreach programs, authored several books for neuro-ophthalmology, authored manuals for allied ophthalmic personnel, published over 55 papers in peer-reviewed journals, and delivered prestigious orations. Aravind's eye model is being replicated in 30-plus countries. And Aravind Eye Care System is the world's largest provider of eye surgeries with a network of 14-plus hospitals and 111 vision centers. All of them are connected to teleophthalmology. Her initiatives have helped millions regain sight through affordable eye care. She's a recipient of numerous national and international awards. She was recognized for excellence in service, leadership, and social entrepreneurship. She was awarded Padma Shri by the Government of India in 2024. She continues to inspire a generation of ophthalmologists. Her core beliefs were compassion and care, efficiency with empathy, and service beyond profit. And one more famous quote of her was, "Perfection is not just about sight, it's about purpose." After retirement from active clinical service, she devoted her time to organic farming. Her work continues to illuminate lives. Active in education, social welfare, and environmental causes, she integrated spiritual values with professional excellence and inspired others to build institutions with heart and purpose. I have written a small poetry about her. In once dim, she kindled sight. Dr. Nachyar's care turned darkness to light. Aravind stands, her dream comes true, a beacon of hope in every view. Through countless eyes that now see the dawn, her legacy of love forever lives on. For vision she gave, not as a routine part, but through wisdom that shines from her heart. So I present to you one of the greatest leaders in ophthalmology, one of the greatest legends in ophthalmology, Dr. G. Nachyar, ma'am.
Let's start now.
Yes, ma'am.
Thanks, ma'am. Yes, ma'am.
Thank you very much, Sujata. I think it was a beautiful introduction, especially the last one. I really enjoyed that one. And I would like to congratulate the entire TNOA team for organizing, many educational seminars, webinars to all the young ophthalmologists and also busy ophthalmologists. And It's something new for our older people like us. So keep going. Congratulations. And I would like to bless all of you with that one. And thank you for giving this opportunity to meet all the youngsters and all the eminent ophthalmologists. Now, today I thought, let me share my experience, which may be like a story or which may be like a history. And for the women who are ophthalmologists, why ophthalmology is so special among all other specialties? Now, let me carry you. Ophthalmology is a very rewarding specialty. You're not only giving sight to the person, you're also giving life and light to the entire family. I don't think you're thinking wider and deeper. You may do a cataract, or you may do an RD, or you may do your ptosis surgery, or you may do anything in the eye. You're treating the entire family because the benefits not only belongs to a person, but to the family. The second great advantage, especially for women, you can plan your professional work without much disturbance of your personal life. Not much emergencies, not much casualties. And lastly, you own all the organs in the body. As a result, you will be the hero or the heroine for the entire medical profession for referral if you prove yourself. Now, I used to like this eyes or the windows for the body. In early days when I became ophthalmologist in the year 65, I was not aware that through eye, we can see the entire world. Today, with all the technology, the eyes are the real windows for the body. For example, if you peep through a window, of a house, even if the house is closed, you can see at least 50% of the people who are there, the culture of the house, the numbers of the family, and children, at least to a certain extent. So as an ophthalmologist, you see the entire body through a small instrument, ophthalmoscope, and also by the external examination. The other important aspect, eyes are the windows for the soul. When you smile, the pupil dilates. When you feel depressed, the pupil constricts. And so much of dancing occurs in the iris. So much of dancing occurs in your lid, your eyebrows, your staring look, your loving look, your hatred look. Eye can represent the entire body and you can even reach the soul. Sometimes we used to think, that means it's not external. Somehow you don't like a person, something is there. Either you look through the eyes or look through the feelings of it. Now, just to recollect, all of you think, or all of us think, the eye is eyeball, the orbit, the muscles, and the lacrimal apparatus, and the optic nerve. But I always feel God must have created a more space inside the brain than externally. Whole transformer is here. Without this, eyes cannot function. So maybe there's a lack of place outside. So God has rented place in the brain for visual pathway. Imagine the eyeball, the optic nerve, the chiasma, the tract, and the radiation, and the occiput cortex. From frontal lobe to the occipital lobe, our transformer is there. So if you imagine now, the entire brain has this structure. So any insult to the optic nerve can occur either through the temporal lobe or frontal lobe. And anything can go wrong for chiasma if pituitary is not functioning, tract, middle brain, everything. So the eye and the brain are first cousins if you can take it as a body. The blood supply and the vascular drainage are also shared by the brain and the visual apparatus. So why I'm showing this is how much we are connected to other structures in the body. For example, carotid system, CR, central retinal artery or a central retinal vein comes from the carotid system and the vertebrobasilar system. So it also, if you look at the last picture on the right side, the whole chiasma is embraced or engulfed by the circle of Willis. So aneurysms, leakage, stroke will involve optic nerve and the chiasma. Similarly, the venous drainage for brain and eye are same. Cavernous sinuses, superior sagittal sinuses, inferior. So any obstruction in the brain for venous drainage will produce problems in the eye like central retinal vein occlusion. And totally we have 12 cranial nerves, of which 6 cranial nerves belong to ophthalmology. Optic nerve, oculomotor, trochlear, abducent, 5th division, ophthalmic division, 5th nerve, 7th nerve. So out of 12 cranial nerves, if 6 nerve involvement can be seen by the ophthalmologist, can guide neurosurgeon or a neurologist. So any healthy brain, our visual pathway is healthy, but any insult in the form of tumor, congenital malformation, injuries, inflammations, anything will involve the eye in the form of vision or pupils or fundus changes. So again, it's an opportunity for a general ophthalmologist. With this connection, you will be able to diagnose many problems of neurology and neurosurgery, and you can refer the case early, and you can save not only the vision, but also the life of the patient. And all you see is the fundus, the pupils. Now, because of your technology, you directly get into the fundus. I think if you go through pupil, the pupil can talk to you a lot. Size of the pupil, shape of the pupil, pupillary abnormalities, so reaction of the pupil, all will give you some clue, but you are in a hurry to look into the fundus or look into something which you already know. And you're not interested in seeing something which you don't know or you don't try because of either a pressure of the time or the routine, you depend on the machines too much. Look at the muscles. Look at the motility. Look at the field abnormalities. You can, even if you don't do a field, the way he walks, the way he sits, the way he reads the Snellen's chart. Look at the proptosis. Endocrinologist will not go to a thyroid exophthalmos will not go to endocrinologist. He'll think something wrong with his eye. So these are all, you should be familiar as a routine examination so that you won't miss anything. Anemia, in our days, we look at the conjunctiva, but nobody looks at the conjunctiva now. You all look for the tear film, but you don't look for the anemia because it's not your job. And jaundice, we always look before the bile salts, we look at the conjunctiva for discolorations. And these people won't go to endocrinologist in our days. They always come to us. And whether it is a bilateral proptosis or unilateral proptosis, the problem on your right side, these things don't come to us. But the things that you see on your left side will always be there, and it's your duty to connect both and then refer them to appropriate either endocrinologist or the neurosurgeon or the neurologist. Now the diabetes, especially now it's almost 50% they are predicting in the year 2030, and everybody has some sort of a changes in the diabetes, especially 1 and 2 young juvenile people. When you look at them, they will say normal vision, and they may come for a refractive error, they may come for chalazion, they can come for a pterygium, but if he's a diabetic, it's an opportunity for you to detect the entire fundus. Similarly, in a hypertension, because the same arteries are sclerosed, The same cardiac problems are seen in the eye through these vessels. Cardiac, they say if you look at the AB ratio in the retina, you can predict a stroke in that patient by the sclerosis, by the yellowish deposits. So you can even predict paralysis. You can even predict myocardial infarction by looking at the eye. But when we look at, or when you all look at your fundus, you want to look something and you're looking only that one. Even if the other things are there, your mind doesn't see them or your brain doesn't register them. I'm sure whether I'm able to explain to you clearly. You have decided your diagnosis early, and that diagnosis is in your brain, and you see what you want to see and what are there which may not attract you. The digestive system. Now the dry eye, as once we have never heard about it. Now they say the maximum selling of the drug is the artificial tears, and it is becoming so expensive, and it's a man-made disease. It's a lifestyle disease, but digestive system also can produce dry eyes. Similarly, respiratory system. All this spring catarrh, we used to call it as an allergy, but now they say bronchial asthma has got this sort of goblet cells in the palpebral conjunctiva under the limbus and localized congestions. Suppose if you see this and ask the patient whether you have any respiratory problem, a patient might say that's a different one. But if you try to connect, you become smarter and you become closer to the patient. This is very obvious, nephrotic syndrome. They go to person, but if they don't refer, you may lose him for completely. But when you happen to see this, you can always refer to a nephrologist. In our days, we used to see a lot of eclampsia. We had a separate ward, eclampsia ward, where you can smell paraldehyde injections. Now also is there, and the hypertension is there during pregnancy, and also this sort of bacterial infections. Now recently, a new terminology called autoimmune disease affects every cell in the body. Anything, especially when in the Western countries, if you don't know the diagnosis, madam, it's a stress-induced autoimmune disease. But that affects uvea 100%. And I missed one point, respiratory system. One VIP person came to us about 20 years back. He had a small iris nodule like a tubercle. And then when they diagnosed it, he had a big tuberculoma in the colon. So it's really a window, but if you don't look it, if you don't anticipate it, if you don't have an intuition, you won't look at it. Now that's about the changes in what we see. The eye is the window. I think now you'll have an idea. For any patient who comes to you with any complaint, please look into the eye as a whole and person as a whole. Now, what are the things that changed in ophthalmology in my period? I got into ophthalmology in 65 at the age of 25. And I was a clinical person up to 2020. And then I retired from the clinical side and came to HR side. And I stopped my surgery at the age of 58. And I just wanted to share with you why I stopped the surgery at that age. And once, especially late 80s, the IOL period, I was a very, very busy IOL surgeon. And I also had a hydrocephalus. My brain was small, but my head was swollen because those days IOL surgeons were very few. And I was trained in that. So all the VIPs used to come. And I thought I'm the only person who can do a high volume surgery. In 2000, at the age of 59, I was operating in the theater And we had one head nurse called Varghese. மேடம் நாளையிலேருந்து நீங்கள் தியேட்டருக்கே வரக்கூடாது மேடம், இந்த ஒரு வாரத்தில் 3 பீஸ் ரெண்ட் ஆயிடுச்சு. This is what the quotation was. I felt very ashamed because my quality was coming down. That's a truth. You can pretend, you can do a lot, but microsurgery, you need a very precise hand, you need a very precise mind, you need a very steady, conscious attitude. So I didn't go to the theater next day. Then I thought people will wait for me, people will beg for me. Nothing happened. So that gave me a big lesson. Nobody is indispensable. Now coming to the second part of my favorite subject is, what are the things changed from in this 40 years? One, patient attitude. Number two, ophthalmic practice itself has a tremendous changes now. And changes in ophthalmologist, our attitude, and changes in technology, and what did we gain and what did we lose. Now coming to the patient attitude, in my days, this was the situation. The doctor will sit in a sofa with crossed leg. All we had was only ophthalmoscope, a trial set, and a short stonometer. With 5,000 rupees, we started our practice in 65. And patient, what you see on the right side was the attitude. Doctor, I'm not able to see well in both eye. I've come here to see you. What best you could do. You're like my God. Total surrender. Today, this is the situation now. Patient comes to the doctor with the diagnosis. I have an immature cataract in my right eye. Please perform phaco with foldable lens. He has diagnosed it. He has instructed to do what type of surgery and what type of lens, and let me know what lens you are going to use it. So the knowledge, it's very good actually for a patient, because patient is aware of the problem. Patient can read the problem. But sometimes it is irritating for the doctor, but learn to listen with a smile on your face. Now, in my days, I've seen couching, especially in Ramna district. Our chief took us to all and showed us how the couching has been done. And so then when I started, of course, we didn't do a couching, but we witnessed it. We started our practice with ICCE with forceps, then ICCE with a cryo, and no suture. We just reposed the flap. Then came ECCE with 10 to 12 sutures. The more suture, the more surgeon. We were not aware of the astigmatism that time. I thought the sutures, the more sutures, the better surgeon. And we were not aware the sutures have to be aligned to the surface and all. We used to use 80 silk, and it will be irritating and patient will not be comfortable. Then we started SICS and phaco, now so on. So the entire period we have witnessed in the last 50 years now. Anesthesia, topical in couching. Then we gave retrobulbar, and we used to have an expulsive hemorrhage, and we thought that was a common accepted complication. Then came peribulbar. Then came local infiltration. Now again, we are going back to topical. Who knows, we may have a couching later in future, and the lens will absorb in the vitreous. The size of the incision, 1 millimeter couching, then ICCE 14 millimeters, then came to 12 millimeter ECCE, then came 6.5, 3.5, and now the smaller the one, the fashion of the day today. Capsulotomy started with a puncture. When we do a intracapsular graphis knife, we puncture, and with the same knife, we put an anterior capsulotomy and counter puncture at the 9 o'clock. and then raise the flap. Then came cane opener, linear, envelope, capsulorhexis now. Same thing, lens removal, tumbling. Cryo, we used to call, cryo was very, very special to all of us when it came. And then now, of course, you don't have any, now you eat up the lens remnants or other way around, I'm sorry. The lens type, I don't know, many of you may not know, Ridley came in 62 to Government Erskine Hospital. We have a big portrait of him. He put glass IOL in our patient in Madurai. I have seen glass AC lens. And when we started, we used 3-piece. Of course, when I finished, I became single piece. I've never seen a bifocal, never seen a multifocal, never seen a foldable or injectable. Similarly, the wound closure started with no suture, then 80, then 9 and 10 came, then no suture, now no suture. So that is the changes you have occurred. And all these changes are good in certain ways. But when the changes come, we lose our own personality also. We depend on the technology, and you think you're doing the best because you're using the latest technology. A good SICA surgeon is far better than a learning phaco surgeon. I think you should not feel bad about it. And the recent changes in patient perspective, what I saw was, in earlier days, patient trusted, surrendered, because they were not aware of the recent developments. TVs were not there, and your online, the telephone, everything was not there. So whatever the doctor said, they accepted it with full faith. Today, the trust has shifted from clinical knowledge of a doctor to machine and equipment. And I heard many times that patients saying, "Madam, their hospital is air conditioned. Madam, they have the latest machines. Madam, they even give juices. Madam, they have a beautiful dressed up nurses." So all these things are external. So patients should not be carried away, or you should not be carried away by doing this. The skill of a surgeon, the attitude of the people who are working for you, and the place should be clean. And that's going to give sight and not the other things. The doctor's relationship with patients have become more transactional with less personal interaction due to technology. Those days, patients used to stay with us for 7 days. So every day we go to the room for rounds. They used to ask us to sit down. We share a cup of coffee. That relationship is not there anymore because the pressure of the time and the pressure of financial crisis. What is the post-operative vision? Chief used to ask us. We used to say 6-6, but there'll be a lot of vitreous in the endothelium, lot of stray in the thing, and we were happy with 6-6, which is not good now. Now, even if we give 6-5, patient will still say there's a slight glare is there, not able to drive carefully. I'm not able to, at times I get watering. So they become very fussy also about after doing the best surgery. And this is something very tragic. I have produced many endophthalmitis during my early period, during my surgical time. Even then, they'll come for the other eye to me. நீங்க என்ன மேடம் பண்ணுவீங்க? அது என்னோட தலையெழுத்து, அது எப்படியோ போயிடுச்சு, நீங்க நல்லா தான் பண்ணீங்க. Now it's not. Now they all come with, you're not trusting the patient. They come with legal issues. They come with the treasure hunt, like how to involve us. All the trust between the doctor and the patient is missing now. The consultation fee were minimal. I mean, when Chief started, Dr. Venkatsamy started, we started with 5 rupees. and then became 10, and now it's good. There's no problem. With a consultation fee, you should remember that reduces your volume. Because you want to see more patients, more word of mouth appreciation, more of giving sight to people, you should enjoy it. So I somehow feel you can charge a theatre fee, but consultation fee should be minimal. And today, of course, all of us have economical pressure also. Now there's an increase in consultation fees like 1,000, 2,000, which keeps the common man away from your practice. And similarly, the lifestyle also is pressurized, so we need to collect more money. I think, I don't know whether you'll agree, we have lost the human touch or reduced the human touch. It's true everywhere, not only in ophthalmology, not only in the medical profession, not only in the shop, vegetable market, anyway. If you want to buy, you buy, otherwise you keep going. Earlier we had a talk, like for example, doctors spend more time in diagnosing and treating patients. And recently, about few months back, I had a pain in my shoulder. I thought the doctor will examine my shoulder by touching shoulder and all those things. So I had a loose jacket and I went there. The minute I went there, he talked to me and asked for a scan. So I thought, that's a little too much here. Maybe a small joint pain or a dislocation. So this happens to everyone, even for us. When they say headache, you think you have 3 or 4 diagnoses in your mind and your brain acts in those directions. But if you have an open mind, look at the patient first. Look at the person. When you look at the person, you look at his economical condition, look at his educational status, look at his pain, look at his agony, look at his anxiety. And Chief once asked me one question long back when I was a postgraduate student. How will you differentiate a blindness due to CRA occlusion, a blindness due to RP, a blindness due to congenital blindness? I'm sure all of you will understand. A chronic blindness like congenital blind will walk comfortably. An RP blindness will walk comfortably with a limited field. But a CRA occlusion, it's not the CRA makes him, the anxiety of the face, sudden blindness of that morning, or all those reactions will be there in the face before you touch your ophthalmoscope. So similarly, when you examine a patient, look at the patient with the disease, not the disease without a patient. And it's more a technical, less personal, and changing in the billing practice. You should see the financial situation. Of course, you have to charge because we also need to live. But that depends upon, for example, a patient need not have a foldable up-to-date lens costing about 1 lakh. You can, 80-year-old person like me, need not have a very sophisticated, because my lifespan is short. So what that patient needs, what you need from a patient, that's different. And I somehow feel there is a shift to business-oriented approach. A lot of corporate sectors are coming up, good, which is good, which we need more of. The approach should be through your heart and not through your technology. Now, this is, even today when I asked my PG, madam, we saw one very interesting case. I said, what was the age? Wait, madam, I'll go and see EMR and come. Because he has not seen the patient age. So he sees the eye, not the gray hair, not the bald head, not the wrinkles, not the expression. So that patient, that doctor has got a limited ophthalmic knowledge and wants to see that symptoms relating to that knowledge. And when we talk to a patient in our days, we used to get a lot of informations. Madam, my father had a similar disease. My mother was blind. My, RP could be. So many clues you get it, or so many intuitions you get it, which you are missing nowadays now. So And earlier, they used to stay for 7 days. We used to have a lot of interactions, lot of, even I have conducted 3 or 4 marriages within our patients because they were staying in one floor. One floor patient wanted a girl, the other floor patient wanted a boy. It's very interesting lifestyle was there. But today, you don't know, you're operating a male, you're operating a female, you're operating a rich man, you're operating a driver, you're operating a farmer. You're looking only the eye, which is not the right way. The efficiency of the care is increased. Definitely, the quality of life for the patient is definitely much better than our days. The infection rate has reduced to 0. I totally agree. But the relationship of the patient and the doctor is decreasing gradually, become more mechanical, and you don't have time to see the patient's face. You don't know the relationship and the thing, because the patient also will have the same feeling about you, and then he is more smarter. He can talk outside about you a lot than you talk about the patient. And there is a feeling among the patients, the higher the cost, better the treatment. And that mindset also is there. So some of the people, consultation fee is only small, so it may be a smaller hospital. Oh, you cannot see him normally because his consultation is high. That sort of a belief is not good for your profession. And machines and technology are becoming dominant in healthcare. But in some cases, they are replacing the experience and clinical knowledge of doctors. So what did we gain in these changes? Technological advancements in equipments, surgeries, investigations, drugs have simplified medical work. But at the same time, we have a lot of opportunities which can increase our field of work because of the advancement in science. And these developments allow for a higher volume of patients, earlier diagnosis, and quicker treatment. Like CT scan, MRI, when I was doing by neuro-ophthalmology, were not there. So by looking at the pupil, I was trained by Professor Walsh in Baltimore 50 years back. He diagnosed a pontine glioma by looking only at the pupil. I mean, he was looking at the pupil for about 30 minutes. That pupillary reaction, pupillary size, pupillary flutter gave him the diagnosis of pontine glioma, which was confirmed by the neurosurgeon. That sort of knowledge, clinical knowledge, and the experience made him a great neuro-ophthalmologist. Now, teleophthalmology has enhanced both patient examination and training method, and training young doctors by simulators and webinars. What you're doing is great. We never had these opportunities. We never had much scientific papers. We never had any conferences those days as you all do here. And publication research work completely were not there. And now it's much more. But what we have lost, not only in the profession, but personal, there's a personal interaction. We talk to a phone friend a longer time than with a patient. And the history eliciting, we used to spend a lot of time. I mean, all the systemic examination will give us an intuition to look what you really want to see in the eye. And limited face-to-face contact absolutely is reduced now. And before modern equipments, all the technology, we were depending on our experience, intuition. Somehow this intuition is not there now. And we used to get intuition when you look at the patient. Could it be a neurofibroma? Could it be an acoustic neurofibroma? If you see a small wrinkle in the iris, a small ectropia, small fibrillary membrane in the pupillary area, a small degeneration in the retina, will give us some intuition to follow it up so that we'll be correct at the end of the examination. Today, doctors often rely on expensive scan rather than clinical examinations. So I somehow feel there's a decline in clinical knowledge, all those things. Finally, the impact of an ophthalmologist's work extends far beyond the clinic walls, reaching the heart and lives of every patient they touch. It's a great gift, how much they talk about you. You won't have time to talk about the patient. But one operated patient will talk to 100 people, either in the house or the neighbors, not only about you, about your nurse, about your toilets, about your medicines, about your bill. And similarly, anything is good, they'll also talk. Anything bad, they'll also talk about that. So in conclusion, we need technology. Absolutely, there is no doubt about it. But at same technology, if you can add humanity, human touch, where are you coming from? How are you? Spend 1 or 2 months. டாக்டரே என்கிட்ட அவ்வளோ 2 வார்த்தை பேசிட்டாரு, அவ்வளோ கூட்டம், அவ்வளோ நல்லா பேசினாரு. That blessing you need. And your own employee, sometime back I received a peculiar comment from one of our patient, a long period patient. Madam, hereafter I won't come to your hospital. I said, why? I was parking my car in the portico of your outpatient clinic, madam. The security behaved, area car. He was shouting at me and I was feeling so embarrassed. So a security can stop patients coming to you. So you treat your employee, share your vision and mission, and you should be a role model for all your employees, and your employees should be your partners, because you may eliminate needless blindness for the world, but without them, you cannot. So make them understand the importance of it, and then the profession should allow us to serve and earn a living while gaining trust and respect within the community. So all of us, all the younger generations, spend little more time clinically and use your clinical approach. Definitely technology will enhance our work, but never ignore them, because these are your spokesmen, these are your messengers, and these are the people who are going to give you the blessings. So thank you very much for giving this opportunity. And if you have anything to ask, I'll be happy to answer.
Madam, you're
Thank you so
muted.
much,
Sujata, madam, you're muted.
for your wonderful presentation. We all know neuro-ophthalmology is your pet topic. Thanks for sharing with us. And of course, the next part is the patient quality eye care. Madam, in fact, you are the role model to all the women ophthalmologists to balance the family and profession. Not only for the woman, I feel the whole ophthalmic fraternity, you have set the gold standard of compassionate patient care and quality eye care with ethical practice. So we are very, very happy to go through how you have brought out all this attitude and the work culture within your institute. So the only thing I just want to know, how you can inculcate the vision and mission of Aravind eye care system into all your medical and paramedical faculty.
Svishna.
How do you inculcate the culture?
Shalini, you must be knowing it because I know you as a child from the beginning. Actually, all my, it's not my vision or anybody's vision. It's Dr. Venkatsamy, who was almost like my father. The difference between both of us are 25 years. He was not married. So after his retirement, either he wanted to join Aravind Ashram or started a small clinic. My mother was said, we are only farmers, not from big business people. My mother wanted my brother to be with her. So she said, I'll give some money, you start your clinic. So that's how we started a small clinic in Nayakar New Street. And then when he was not happy, then when he retired at the age of 60, he said, can we start a small private clinic? That's how we started with 11 beds. And at that time, Dr. Vijayalakshmi, her husband, and joined. Then we were 7 people. We were lucky because Dr. Venkatsema was giving orders to us, but he was not surgery. He was not doing surgery. Myself, Dr. Vijayalakshmi, my husband, Dr. Nambarmal Sami, and Srinivasan, all the 4 were doing surgery. And we used to start at 4:30 in the morning, come back to the OP at 7:30 because we needed money. And then Srinivasan, I had one more brother who is very, very frugal person. He will, even if he lose 1 rupee, he will search for 1 day. You know, he was a building contractor. He was building the hospitals. And then Tulasiraj later joined us. He was the MBA. So 1 management person, 1 engineer and finance, 1 visionary leader, and 4 ophthalmologists. That's how we started. And
Fantastic.
gradually we expanded. It's just a pure hard work, and it was credit must go to Dr. Venkatsamy. And I have, I never appreciated him almost for 10 years till we were recognized by others. So I was like anybody else at that time.
Ma'am, I think when you do so much of good work, I think God is always with you. So automatically it will flourish, ma'am. So
Every-
automatically it will flourish because God is
I
there.
totally, yes, Sujata, you're absolutely true. Even when my husband passed away, I was feeling very lonely because I lost my brother. I mean, when we started this institution, we were all together.
Yes, ma'am.
The elders, all the elders have gone. I am the only person living at that time. My lifetime also is not. So I felt very like an orphan, even now. Then I realized how many people will have this opportunity to have a institution and have a purpose to live, a good people and a good family. So I'm lucky in that way. Now and then I feel a little bad, upset, and then I become honest. All of you are doing much better work now, and we were very ignorant earlier.
How was your interest in organic farming started, ma'am?
Our parents are farmers. My mother was a great farmer. Our village is a very small village with 70 houses and dry lands. I lost my father when I was 8 years old. And my mother, as a young widow, she cannot read and write, absolutely. But she had so much of leadership, so much of common sense. She sent all of us to other countries those days, 50 years back. We studied and we came out. And because of the farming, we are all quite familiar with the land, hard work. And my mother used to get up at 4 o'clock. You're talking about what is called professional and family. And then a family. The recent, what is the modern language you talk? How do you balance yourself?
Work-life balance.
Work-life balance.
That's my mother used to go at 3:30 to farm. So where does the work-life balance come? Now that's all excuses. Because in ophthalmology, you can get all that work-life balance. And I was interested, and it's not my personal, the Oral Lab had some area. So I thought I'll start organic farming. And I really enjoy it because one, they won't talk it back like people. And I enjoy it. Professionally, I see good results and I enjoy it. And you should also have an alternate. Don't cling on to ophthalmology forever. Come to the administrative side, because administration of an institution is very, very important. Because success story is not in the surgery. I think you must be knowing it. Running an institution does not depend upon the doctor. Depends upon the person who takes care of the minute details of the hospital. Same thing.
Absolutely, ma'am.
Madam, what is the secret of your high energy, madam? It's the same like what we have seen 40, 50 years back, ma'am. It's the same. So any special mantra, madam, like meditation, spiritual journey?
இந்த மாதிரிலாம் இப்ப மாடர்னா பேச ஆரம்பிக்கிறீங்க, அதெல்லாம் இல்ல. We are all old people, and என்னோட expectations are very minimal. And I'm happy, as Sujata said, I have everything in my life. God has given me everything, and I cannot ask for more.
Madam,
But
can I ask one? Sorry, madam. Can I ask one question? How did the name Arvind come to this hospital?
Sri Aurobindo, Pondicherry, Sri Aurobindo and mother. Sri Aurobindo was a freedom fighter, philosopher, and he believed Karma Yoga. That is, you do good work and reach the God. Then do. So that actually, Dr. Venkatasamy became the disciple, and as a result, we named it as. It's not Dr. Aravind. It's
Yes.
Sri Aurobindo. மெட்ராஸ்ல டாக்டர் அரவிந்த் இருக்கிறதுனால நீங்க அவர் பேர்ல வச்சிருக்கோம்னு நினைச்சிடாதீங்க.
Madam, many of them are at the verge of retiring. So what will be your word of wisdom to them, madam? Like, இப்போ already Dr. Shalini has following her, your footsteps.
Yeah, Charlie has an alternate one. She runs a good school. Husband runs a business. You should have it. I mean, you should have something in your dance. You can do yoga. I mean, you're good in many things. But think of retirement at the age of 60. Don't cling on to ophthalmology or become an administrative person in your institution. Because administrative will bring a lot of efficiency. As a HR, I've done a lot for the institution than as an ophthalmologist. I love that subject. You can become a HR, manage the whole people, 10 people or 20 people, or go to a field which is because ophthalmology after the age of 60, surgical ophthalmology, you can pretend, but it's not safe for that's what I think.
Ma'am, regarding the middle level training program for women, how did you convince the parents that that this sort of training will help them? You know, because they have come from rural areas, they are very poor. How did you?
You are talking about allied health
Yes,
personnel.
yes, ma'am.
Yeah, that we started because we didn't have anyone. Even now, you cannot have an ophthalmic nursing.
Yes, ma'am.
BSc nursing is there, other things are there. But ophthalmic nursing, you cannot depend on BSc nursing for ophthalmology. So in our village, our own relatives, we brought about few girls in 65, in 70. And we gave them in-house training for 2 years. There was no module or no structured syllabus. But 10 years later, now we have a very, very specific program. And but selection criteria is very stringent. We don't advertise it. And it's a compulsory in-house training. And we give them a decent salary. And we try to give them, if possible, if they're very good, we try to find a boy or a girl for them. Then if they're really good, we have a provision to give a vision center in that area.
Okay.
Take care of them. That's a secret, Sujata. One thing, you have to meet your employees frequently. Your husbands will be very busy, but you meet them. I mean, it's not fake. That's a truth.
Absolutely. Absolutely.
Madam, I want to share with them the motherly way of madam preparing healthy, nutritious drink for all the staff in her organic farm. Every day she prepares and sends it to her employees, just like her own children. So the care, the bond she develops with them, naturally, they also reciprocate very well.
Absolutely true, Salini. Absolutely true. The other thing, spend some time with your children and grandchildren, because they may not like it initially, but observe them and love them. You accept it, no harm, but don't stay away from their problems. Get them involved. Indirectly, somehow you have to support them in the right way. And if they are in a wrong way, you have to stop them. Children, especially grandchildren, you have to have some step forward. கொஞ்சம் அந்த லவ் எல்லாம் பண்ணி எங்க பாட்டி மாதிரி உண்டான்னு அந்த மாதிரி உண்டாக்கிட்டு அப்புறம் now the growth of children are not very safe, because that decides their future also. And that homework I do a lot in Aravind, because if you look at our whole family, most of them are ophthalmologists. My grandson is doing ophthalmology. I asked him about 2 weeks back, தம்பி அரவிந்த் வந்து இவ்வளவு நல்லா இல்லைன்னா நீ அரவிந்தில் சேர்வியான்னு. அது எப்படி சேர முடியும்? நல்லா இருக்கிறதுனால தானே வர்றோம். He thinks somebody has to keep the Aravind in a good way so that he can join. Now I said, what is your responsibility to make Aravind better? You have to make them understand. If you are coming down in your institution, everybody will run away. You have to remember that. Even in your own children will run away.
Yes, ma'am.
You are able to understand. I think Sujata will be able to. Shanta will. All the three have your children ophthalmologists. Only when they may criticize you, they may think anything else. But the minute that comes down, they'll blame all others except themselves. That's it. Thank you, Ma'am. Really grateful. And I don't know whether it's useful, Dr. Vijay Raghavan, I don't know whether it was useful for you, but
Fantastic,
it was my
madam.
journey.
Really enjoyed. It's very nice.
Ma'am, good evening, ma'am. Hello.
Mohan Rajan, sir.
Hello, madam.
Yeah, hello.
Mohan Rajan.
Oh, what a pleasure to see you, ma'am.
ஐயோ பா
What a pleasure to see you.
ஐயோ நீங்களும் உள்ள இருக்கீங்க. நாங்க நிறைய அட்வைஸ் எல்லாம் கொடுத்துருக்கோம் சுஜாதாக்கு.
இல்ல நான் இப்பதான் வந்தேன். Sorry, இப்பதான் I'm joining now. Yes.
She's finished.
Hi.
Thank you.
Sir, VRV, sir, you were saying something, sir.
No, that was a great lecture, madam. Actually, we learned a lot also from you. What was previously it was how was the ophthalmology, how it has developed now.
கேட்கவே இல்லை.
You will develop ஆயிருக்கு.
Not able to hear you.
கேக்குது.
You can't hear.
We are low things and we have learned a lot how ophthalmology has evolved. So much learning, it was excellent and so on.
And nowadays I have seen the a tendency for all the residents and PGs, they are more in favor for surgeries rather than learning the subject.
ஆமா,
That's what I have seen.
ஆமா.
They want cutting chance. They used to tell me. That's all.
True. Because they think and the surgery, they don't think that patient is more important. அதாவது ஏதாவது சர்ஜரி பண்ணணும், அங்கே எவ்வளோ சர்ஜரி சான்ஸ் இருக்கு, இங்கே எவ்வளோ சர்ஜரி சான்ஸ் இருக்குன்னு கேட்பாங்க. And I mean, they don't realize it. I mean, just surgery தான் அப்படின்றது ஒன்றும் இல்லை. Even by giving a good glasses, the patient becomes your slave. So அது அந்த ஒரு ஃபேஷன் தான் சார். அது ஒன்றும்
Correct.
ஆமா. I think once they rupture PC twice, when they rupture, dislocate the lens, ஓடிடுவாங்க.
That's a good
அப்பதான் இந்த இனிஷியல் பட்டிங் இருக்கும்ல சார்,
Correct.
அந்த டைம்ல இருக்கும். நீங்க சரி பண்ணன்னு விட்டீங்கன்னு வச்சுக்கோங்க, ஒரு டிஎம் ஸ்ட்ரிப்பிங்கோ இல்ல ஒரு பிசி ரெண்டோ, அப்ப கூட என்ன சொல்லுவாங்கன்னா, பேஷண்ட் நாட் கோஆபரேட்டிவ் மேடம், பேஷண்ட் பிளாக் இல்லை மேடம், பேஷண்ட் ஹை மயோபியா மேடம், அதெல்லாம் இருக்கும். பட் யூ கிவ் them an opportunity and see their ignorance. அவ்வளவுதான்.
Thank you,
Well,
madam.
some of the doctors who joined us from Arvind used to tell us, some of the doctors who joined us from Arvind Eye Hospital, they used to tell us that you used to see the post-op for all their post-ops. All the post-ops, just amazing, because that needs a lot of, to see free patients post-op, it needs a lot of effort, and the amount of interest that you had in the patient, that shows, madam.
அது இருக்கு. Sometime when they come to us, it's our duty to train them. Our theater will be over by 1 o'clock. So I stay in my room and have a lunch. 1:30 அங்க யாராவது ஒருத்தர் நின்னாங்கன்னா, either they must have rented a PC or they must have dislocated a cataract lens into the vitreous. Something must have happened. So we know. தெரியும். அந்த ஒரு பயம் அவங்களுக்கு இருக்கணும் இல்லம்மா.
Yes. All eyes are very important. Each eye is very important.
I enjoy my teaching and training. அது எனக்கு பிடிக்கும். அது
Madam, your lecture was beautiful.
ஐயோ பரவாயில்லம்மா.
And
I just
really
wanted
an
to
eye
get-
opener. See, we know everything, but coming from a person like you, it is really.
இல்ல இல்ல, all my thing is now doctors make the diagnosis without even taking an instrument. கண்ணு தெரியலன்னா அது கேட்ராக்டா தான் இருக்கணும், கிளாக்கோமாவா தான் இருக்கணும், அப்படி இல்லாம அந்த நோயாளியோட பேக்ரவுண்டையும் தெரிஞ்சு பார்த்தாங்கன்னா இன்னும் கொஞ்சம் அவங்க இப்போ நியூரோஆப்தல்மா எல்லா கேஸுமே இப்போ ஐதாம விண்டோ.
Absolutely.
ஆட்டோஇம்யூன் டிசீஸ்ல யூவேடிஸ் வச்சு நீங்க எந்த ஆட்டோஇம்யூன் சொல்லலாம் அப்படிங்கிறாங்க.
Yes, ma'am.
இவ்வளவு அழகா இருக்கு இப்போ கிளினிக்கலா. அதை விட்டுட்டு யூ லுக் ஃபார் டயக்னோஸ் விச் யூ வாண்ட் டு நோ. கிளாக்கோமாவா தான் இருக்கும், டயபெட்டிக் ரெட்டினோபதியா தான் இருக்கும், ரிஃப்ராக்ட் எரரா தான் இருக்கும், அந்த மாதிரி ஒரு இன்ட்யூஷனோட பாக்குறோம்.
Yes,
அது
sir.
தப்பு.
Looking at the patient as a whole is very important.
ஆமா ஆமா, பேஷண்ட்ஸே சொல்லிடுவாங்க உங்களுக்கு.
Yes, madam.
அப்ப இருக்கிற அப்ப வந்து டெக்னாலஜி இல்லாதனால we used our brain lot. இப்போ எது எடுத்தாலும் ஸ்கேன் எம்ஆர்ஐ இல்லைன்னா டாக்டர் பார்க்கவே மாட்டேங்கிறாங்க. நீங்க வந்த உடனே எல்லாருக்கும் என்ன பண்றீங்க, அல்ட்ராசவுண்ட் கேக்குறீங்க, ஓசிடி கேக்குறீங்க. முதல்ல ஓசிடி வாஸ் ஒன்லி இன் கிளாக்கோமா, இப்போ ஓசிடி ரெட்டினா, ஓசிடி எவ்ரிதிங். அது ஒரு பிபி apparatus மாதிரி ஆயிடுச்சு இப்போ. அரவிந்தம் தான் எல்லாரும். கிளினிக்கலா என்ன இருக்கும் அப்படிங்கறது இன்னும் கொஞ்சம் நம்ம ஸ்பெண்ட் பண்ணா நல்லா இருக்கும், டைம் ஸ்பெண்ட் பண்ணா நல்லா இருக்கும்.
Also, there is a medico-legal issue, madam. Now, what they are saying is, when you have the investigations available, why are you not doing? So that medico-legal aspect also we'll have to see. So in addition to street, you do have to do these investigations.
அப்படி இல்லைம்மா, அதை கான்சியஸா நமக்கு வந்து அது தேவைன்னா கட்டாயம் பண்ணி தான் ஆகணும். பட் ரொட்டீனா வந்து உங்களை டெஸ்ட் பண்றதுக்கு முன்னாடியே ஒரு சீட்டை கொடுத்துட்றாங்க. ஹேப்பன் டு மீ. ஐ மீன், சரி இந்த அம்மா இந்த வயசு கிளவி இருக்கு, ஏதாவது ஆர்த்தரைட்டிஸ் இருக்கலாமா என்னன்னு பார்க்கணும்ல. ஒண்ணுமே பார்க்கறச்சுன்னா ஐ ஃபீல் ஐ வாஸ் இன்சல்டட். கஷ்டமா இருக்கும்ல. நான் நேராக போனேன்னா ஒரு டாக்டர் வந்து கொஞ்சம் கையை தூக்குங்கம்மா, காலை தூக்குங்கம்மான்னு ஏதோ சொல்லணும்ல. அந்த மாதிரி இல்லைன்னா அவங்க பேஷண்ட் என்ன நினைக்கிறாங்கன்னா தொட்டு கூட பார்க்கல, அவங்க என்ன டாக்டர் அப்படிங்கிற மாதிரி ஆயிடும்.
Yes, absolutely right. Absolutely right, madam. So does
Yes.
panel, any more questions from the panel? We can.
I must only say, madam, it was an honor to sit along with the GN madam and listen to her.
I enjoyed.
So impressive for me and it's still motivating. Thank you for the opportunity, madam.
Thank you, and thanks once again, ma'am, for giving us this opportunity and making the
pleasure.
first edition of Meet the Legends such a wonderful.
I'm so honored, so
Thank-
honored and happy, and thank you very much for the opportunity.
Thank you, ma'am.
Thank you, ma'am.
Thank you, sir. Close பண்ணி.
Very nicely, she is super. Super.